quickly, the Older Adult Behavioral Health Initiative was created and funded by the Oregon Health Authority in 2015. And there's 24 specialists assigned to one or more counties throughout Oregon, and we are contracted and co-located at community mental health organizations. And so we address the unique needs of older adults and people with disabilities with behavioral health needs. And as a role as specialists, we collaborate and coordinate within systems of care. We help build community, our knowledge capacity through free workforce trainings and community education. And we also offer complex care consultations for people within our county that see clients or people in their community that maybe need to have a little bit more system navigation help, any sort of referrals, and we be able to provide that. So you can find more information about the initiative at the oregonbhi.org. And this is the information for the 3 specialists that are hosting today: myself, Linda Jones, and Janine Greenwell. We have 2 more events coming up for the series on the 22nd and the 29th. You can still register for those. And then we also have a advanced care planning workshop specific for the LGBTQ community, and that is July 27th. And all of these registrations can be found on the Eventbrite page. And so I want to introduce Debra Johnson. Debra currently works as one of the team volunteers in Southern Oregon with End of Life Choices Oregon, where she provides education, guidance, and support for individuals wishing to pursue medical aid in dying. She is also the team liaison and intake coordinator for inquiries regarding information and guidance on the use of VSED. And she is passionate about her work with death and dying and advocates for being prepared, thinking deeply about one's values in life, and encourages open and honest discussions about how one would like to die when their time comes. She's recently been certified as an end-of-life doula, and she's working to build her practice here in Southern Oregon. Debra holds a master's degree in gerontology from San Francisco State University, is a certified end-of-life doula, and was certified through the California Pacific Medical Center as a spiritual care companion in 2008, and worked as a spiritual care companion at Marin General Hospital within the chaplains department. And she worked as a geriatric care manager in the San Francisco area for 15 years before relocating to Ashland in 2016. So we're very glad that Debra is doing this presentation for us, and I'm going to hand over the screen to Debra.
All right, can everybody see my screen okay? Yes, all right. Well, thank you so much for asking me to do this presentation, Angela. I'm really looking forward to it. I am, as I say, I'm a volunteer with End of Life Choices Oregon, and I do the intakes currently for this organization. So I take all the calls from anyone throughout the state. And we get quite a few calls, from people that are interested in talking about VSED. So I'm going to just use VSED. I'm going to use it as a verb and as an adjective. So, if you want to do, if you're going to VSED, that means if you're going to voluntarily stop eating and drinking, or if you're going to use VSED, I use that interchangeably throughout this presentation. So what is VSED? A person, excuse me, I'm going to stop for 1 moment so that I can close. Do you know, Angela, I'm sorry, how do I close this side panel? Do you have any idea? The side panel so I don't see everyone up here. And oh, I know, I think I got it.
You go to full screen and it should close.
I got it.
Yeah.
Okay. Sorry about that. So So VSED is an effective option to limit one's suffering and to hasten death by fasting from food and fluids. Someone doesn't live a long time if you even take a sip of water or any other fluid, it will lengthen the dying process. It's a voluntary choice by a person with full decisional capacity. It's a well thought out decision chosen by an individual due to chronic and imminent suffering. It does not require a doctor's authorization or a terminal diagnosis of 6 months to live. It is supported by many hospice organizations. It is an option to die that is initiated and controlled by the individual. Who chooses VSED? Well, someone that's unable to swallow and do the process it takes, to do the life-ending medications using the Death with Dignity law may choose VSED. Someone that has a debilitating illness with a slow but long progression without a 6-month diagnosis. And early to moderate stages of dementia is becoming very common inquiries into using VSED. The problem or the tricky part about this is that a person needs to make a preemptive choice when to make the decision, because they don't want to make it too early and lose out on perhaps other enjoyable aspects and a good quality of life, and yet they can't wait too long before they lose decisional capacity. So oftentimes people will choose to do VSED early on when they still have full mental capacity. Is VSED legal? VSED falls within a patient's rights to refuse medical treatment and care. It is a refusal of health care, and a patient has the right, for example, to refuse any intervention, such as force feeding or having a feeding tube, and they can refuse any food or water. This right, a patient's right to refuse medical treatment, it is grounded in common law, in constitutional law, and in statutory law, and it's legal in every state in the nation. The right to refuse encompasses VSED because the administration of food and water to a patient is a medical treatment that can be refused like any other medical treatment. And though VSED is a legal and accepted option, this does not mean that any specific clinician or healthcare facility must participate. Clinicians may still assert conscience-based objections and refuse to participate in care for a patient if it violates their religious or personal values. So what VSED is not, it is not starving to death, in which often, you might hear people refer to VSED as, gosh, I would hate to starve to death. That is painful, but it's not starving to death. It is death by dehydration. It is not commonly painful experience. The discomfort from VSED is effectively mitigated through good palliative care measures. So in a 2003 study, you'll see that hospice nurses in Oregon who cared for VSED patients rated their deaths on a scale from 0 to 9, with 9 being a very good death, and they assigned the medium score of 8. So nearly all patients died within 15 days. And VSED is altogether different from an impulsive act of suicide. Sometimes you will hear talk that describe VSED as suicide, and there's varying opinions about it. Some members of the medical community and general community are going to refer it VSED as suicide, but let's just take a look at what the difference is in a typical form of how we usually think of suicide and what VSED is. So acts of VSED, excuse me, I'm just gonna, sorry, there's something on my screen that is, I just have to close it. Acts of suicide by commission is pretty much saying no to life. These can be, gunshot, hanging, drug overdose, jumping off a bridge. These acts are irrational and often the result of an emotional imbalance. It's often devastating to others, and it has to be done secretly and alone. And the person who commits suicide usually has pretty high levels of mental anguish. On the other hand, ending life by acts of omission is saying yes to life on one's own terms. Withdrawing of a ventilator, withdrawing of a feeding tube, stopping dialysis, stopping eating and drinking. These are deeply considered decisions that are discussed with others, or they may, like the withdrawing of a ventilator or feeding tube, if someone cannot speak, it's probably likely in their advanced healthcare directive. So you're surrounded by loved ones, and it's a very peaceful way to end one's life. So you can see how these contrast to the former slide of acts of commission. Is VSED uncomfortable? Having medical supervision and hospice available to control pain, anxiety, and discomfort is critical to ensure that any uncomfortable symptoms are addressed. Hunger usually dissipates within 24 to 48 hours, but thirst can be one of the most challenging and ongoing symptoms to manage. These and other symptoms like muscle cramps, distress, and pain all can be handled through good palliative medication. And also, it really varies from person to person. Some have more difficulty than others. Some people express, as they're going through the process towards the end, a sense of peace, that they can finally stop fighting, and they describe a feeling of euphoria or a pleasant lightheadedness. Researchers have indicated that this analgesic effect is caused by the dehydration, may explain, this response. Excuse me. So voluntarily stop eating and drinking can be understood as a response to the physical, psychological, and spiritual suffering. If you think in this illustration, think of a person having three central domains that are affected when life is interrupted by declining health, either in the physical, psychological, and spiritual domain, or all three of them. But if you think of this epicenter of an earthquake, and here I'm going to say that this physical body is the epicenter of an earthquake, the place in the earth where rupture happens and things from there just begin to radiate outwards, affecting all the other structures that are around the center. And a good analogy to what happens to the foundation of a person's life when they begin suffering from a chronic condition, be it a chronic decline and a loss of any desire to keep living whatsoever. So quality of life is significantly diminished because of a chronic physical deterioration when one can no longer do the things that brought them so much joy in life. You know, a person whose life enjoyment and a person whose life enjoyment and purpose came from so many activities they were able to do now find themselves at a debilitating loss. You know, ALS is an example of what happens here when someone's physical condition starts to deteriorate so much, with the loss of motor control, muscle weakness, loss of strength, falling, difficulty projecting one's voice, and eventually paralysis. This is an example of a client who I worked with. He was a very athletic biker. He biked all over the world, and he had friends and connections all over the world. And he was slowly progressing with ALS for about 10 years, and until he finally contacted me early this year. He was 62 years old. He could no longer take a walk. He could no longer ride his bike. He couldn't garden anymore. And he decided he did not want to keep living, that everything that he used to enjoy was no longer, he could no longer do. So he called to ask about doing VSED. He was very prepared. He had a very strong spiritual perspective as well. And this may impact how ready someone is to do it, but he went ahead and started VSED. He had a very peaceful death, and and his wife was very supportive, and I think it just helped him resolve his suffering. The psychological are issues such as weary of the dying process, loss of dignity, depression, and desire to have some sort of control over one's life. An individual wants to hasten their death so that death can be on their terms with some predictability, rather than suffering the long road of decline that can be ahead of them. And then spiritually, existential suffering is typically understood as a psychological or spiritual condition that robs individuals of their capacity for peace in their present state of being. This includes loss of meaning, hopelessness about the future, loss of self, and loneliness. So only the person, living with their illness, their condition, can know when the burdens outweigh the benefits of continuing to live. So it's a deeply personal decision. This is a study that was conducted by the National Center for Biotechnology, showing the results of patients who indicated their primary reason to seek VSED to hasten their death. So as you can see, physical pain, discomfort came in first, but existential and spiritual came in right after that. And then you have dependence, depending on others. They don't want to depend on someone else to care for them the rest of their life. Social, missing their social connections, not being able to do things anymore with their friends. And then psychological came in as the last issue. But speaking of that, when a person wishes to hasten their death, a psychiatric evaluation may be requested. It is routinely done just to rule out serious depression and any other, if there's some other, in fact, this happened with a friend of mine down in California. he would really wanted to use VSED to die. He had a serious stroke and he could no longer talk, and he again could no longer do the things he wanted to do. He was an avid sailor and he was single. He was kind of a rogue kind of a guy, and he was also a VA vet, and he needed to go to a VA vet facility to carry out VSED, and they wouldn't allow it. And I don't know if, anyway, without a psychiatric evaluation for sure, where they assessed him for depression. And he went through quite a few different tests, and they gave him some antidepressants, and he was on that for a couple months. And he, it really it helped him. I mean, he's still not doing well. He sort of wants to die, but his desire to die isn't as acute as it was before he was on the antidepressant. So sometimes, it is important, and it can, reassess someone's desire to use VSED. So a couple points that are found in different case studies regarding depression is, in depression of mild to moderate severity, a patient's preferences regarding life-sustaining treatment are not significantly influenced by depression and unlikely to change with depression treatment. Another point by a different study indicates that although relatively high levels of depression and anxiety have been associated with decreased problem solving, clinical depression does not necessarily make a person incapable of making their own healthcare decisions. So that point, specifically speaks to, making healthcare decisions such as, I want to die and I want to use VSED to do it. Conversations to further understand a person's perspective. And this is either from the medical practitioner or even, family members, or friends. If you know someone that is wanting to use VSED, it's really important to have deep conversations to understand their perspective. How do I want to live? How have I lived in the past? What's my story? What brought me to this point in my life where I'm just tired of living and I want to die? What are the person's beliefs and what are their values? Preparing for VSED. Weeks before starting the fast, it's really good to start preparing, talking to your primary care provider, finding out if your medical practitioner is supportive. If they're not supportive, asking them if there's another medical provider that would be able to support you in this process. Again, conversations are really important. The sooner hospice is on board, the better, as they will be able to provide palliative care and comfort medications as they arrive. If one lives in a care facility, it's really important to talk to the administrator about one's plans to use VSED. Many facilities won't allow it. And if that's the case, someone has to find somewhere else to carry it out. Getting your POLST and advanced healthcare directive completed is extremely important. And lastly, I always advise people to make an oral recording of the plans to stop eating and drinking, stating why you've chosen this decision. And because this will come up, this will be useful later. And I talk about it in another slide, why this is so important. So what are some obstacles and challenges to VSED? So first, the physician not being on board, and there are many reasons why a physician might not agree to support a patient in VSED. The conscience-based objections from any particular clinician may be based on their own religious or personal values, and that exempt them from participating. You don't have to have a physician on board. It makes things a lot easier because they can streamline getting hospice on board, but it's not an imperative. Getting the necessary 24-hour support. If you're seeking outside of your immediate family and friends and looking to hire care support, this can be very challenging. Number one, to find caregivers that are willing to work with someone, excuse me, that is using VSED. Not only are they often not trained in this type of caregiving, but they themselves may have some religious and moral values that make it difficult for them to serve as a caregiver. It also can be very costly because one does need 24/7 care. Less access to timely palliative care because of delayed hospice entry. This is where having a doctor on board can be helpful, but if a doctor's not on board, there's ways that you can, do a self-admit to hospice by calling hospice a day in or the day 2 after you've started, because you are now in the VSED process and they will likely help you and step in to offer you support. Faltering in determination to carry through. This happens. Sometimes people change their mind, and that's okay as long as they're not too far into the process. It's completely okay to change their mind and come out of the fast. And some people try doing VSED 2-3 times. They're determined they want to die, but sometimes they, just it doesn't work the first time, and they'll try it a couple more times with success. Various facilities do not support VSED, as I indicated earlier. And interference is when the caregiver in the home interferes in the process. And this interference can be subtle. It can be as much as eating in front of the person who's trying to stop eating and drinking. It can be cooking and having all the smells around. And it can even be offering them water, because that's just an indication that the caregiver is having a really hard time caring for someone doing VSED and is not a good fit. So the need, again, I'm going to go over the need for caregivers support because it is really an imperative. Support care must have knowledge of the VSED process and be trained in care for this type of caregiving. They must fully accept the person's decision to stop eating and drinking, and it does require 24-hour care. Talking about the timeline to death, let's take a look. The timeline. So in general, there's a beginning, a middle, and an end. So here, it's about 3 weeks, 17 days, something around that time, but it really does vary based on the person's physical condition. So, this taking into consideration their age, what medications they've been taking for, weeks, months before starting the process. What's their illness? How many comorbidities, so to speak, do they have? What is their height and weight ratio? Their fluid retention, their ability to remain completely free of all fluids, and perhaps their readiness to let go. All of these things will affect the timeline. In the first few days, let's just say days 1 through 4, the person can be quite alert, probably having minor hunger cravings, but they will have more thirst cravings. The cessation of all fluids can make the mouth very dry and uncomfortable. It is important that the person have very good oral care to help keep the mouth, tongue, and lips moistened throughout the process. They may begin to feel various levels of mental fog or grogginess. If confusion or delirium levels are a concern, palliative care team can provide some various medications to help reduce these symptoms. And in these first few days, it's so rare, but sometimes it happens that someone will experience and fall into unconsciousness even as early, in this first few days. Days 4 through 8 is the middle of the process. The person's getting considerably weaker and they're sleeping for longer periods of time. He or she may not be able to just sit up and move around anymore, and starting to need more bed care. So help with going to the bathroom, help with turning and dressing and things like that. Delirium can be more pronounced at this stage. And this is where I want to talk a little bit about why that oral recording that someone made back when they were doing their advance directive or back when they decided to carry out VSED, that oral recording is one's intent to use VSED as part of their advance directive. So if they falter during this delirium stage and they forget, why aren't you giving me food or water? I'm thirsty. That's a chance for the caregiver to just gently bring up that they had decided to stop eating and drinking to hasten their death. Do you remember saying that? And if they don't, it's a good time to play that recording that they made on their iPhone, probably, and play that for them and see if that reminds them. And it's usually enough for the person to continue the process. If, however, they continue to ask for water and they're kind of adamant they don't want to do it anymore, then one must honor this decision, and only as long as it's not too far into the process. The hospice team would be able to consult with you about that. If it's been, 5, 6, 7 days, I would definitely check in with hospice to let them know that this person is wanting to stop. Is it safe to do so? The late stages, the person is largely unresponsive and in a coma. They have little bits of delirium still. This stage can last anywhere from 1 to 4 days. Again, they need, good bed care, palliative sedation, or pain management. This is a image shows a study, the results of a study done with physicians who were involved with patients who chose VSED. It shows the duration of time to death from VSED. And you can see on this chart that the time to death, the median time to death is about 7 days. The study was based on representing 86 patients. So 7 days is about the median. So as you can see, it goes out to almost 30 days here. So 7 days is sort of the median there. As I said earlier, a person can change their mind anytime during the VSED process, so long as they have not begun to go into organ failure, which is the much later stages of VSED. So, in my experience, working with people who have wanted to do VSED and trying to get medical support from their primary care physician or another physician, it's not uncommon for medical providers not to support this option. I wanted to understand this better, and I think it's worthy of mention here as to why there is not more support being used behind VSED as an option to hasten death. And although VSED is legal, it helps to understand why perhaps your medical team may not support your choice. Some of the moral and ethical concerns that may influence a doctor's support of VSED are, well, autonomy, beneficence, non-maleficence, and justice. These are sort of the 4 pillars of medical ethics. Autonomy being a patient has the right to refuse treatment. Competent adults can refuse care even if the care would likely save or prolong their life. So acknowledgement of a person's right to make choices, to hold personal views, and to take actions based on their unique personal values and beliefs. So it all falls under autonomy. Beneficence is the doctor's moral, ethical obligation to do good, to provide benefits to persons and contribute to their welfare. So it refers to an action done for the benefit of others. In end-of-life care, it's the professional responsibility in medicine to relieve pain and suffering, improve mortality, and sustain life if possible, and provide comfort care interventions to relieve suffering. Non-maleficence is the active avoidance of any act that would cause harm. And some might say that there is a greater obligation to not cause harm than there is to do something that might benefit the patient. And that regardless of the patient's wishes, the greater obligation is to do no harm. Now this is, open to interpretation. Again, this is the pillars in medical ethics, and I think each clinician is going to abide by these, but with their own interpreted in their own way, what they feel comfortable with in a deep, with their morals, their moral ethics. And justice is the last of the 4 pillars, and it's the principle in medical ethics that refers to fair and equitable distribution of health resources. That one is not so much applicable to VSED. I think what's most applicable in the conflict that comes up when a clinician doesn't want to support you in a process of VSED is often involve these conflicting principles, non-maleficence and autonomy. The physician's moral code, to do no harm, and the patient's autonomy. But this is what I want to do. I have the right to do this. I have the right to refuse food and water. And so the interpretation and application of these ethical principles make the support of VSED a bit more precarious and thus more challenging to get the support one needs to carry through. So End of Life Choices Oregon provides information and on VSED, and an experienced volunteer can discuss this process with you and anyone involved or someone you may know, and assist with guidance if possible. I had someone just recently that called in, and there was very hard to offer support because it was location. The person could not find anywhere to carry out VSED and had no resources to hire help, had no friends or family to step in. And so that's why that if possible, we do what we can to guide someone and help them get it set up to where, so they know the expectations and the requirements. And sometimes it's just not possible to carry it through because of a lack of what I've talked about here today, lack of support, and lack of someone to really be the quarterback for you. Someone to call the hospice team and make sure that they can do an intake and be there for you when you enter day 2 at the latest day 3. And then this is the information. I guess you don't have to worry about taking notes at this time because Angela said she's going to be mailing this entire slideshow out to you. And so here's the info on EOLD. And I do want to encourage you to take a look. These are two really good documentaries on stopping eating and drinking. The first one is a documentary about Rosemary Brown. She wanted this document to be made and documents her entire process. I think her daughter is doing the video, and it's a really wonderful video. The second one is A Dying Wish, and this was a dying doctor's decision to stop eating and drinking and to die with grace, and that can be found through this link here. So that's, I want to thank you all so much, and so I'm going to stop my screen share and we'll take a look at any questions that may have come in.
Yes, thank you, Debra. We do have a number of questions in the chat. The first one is from Doug. Can a person suck on a damp towel if unable to swallow? No chance of choking on liquids.
Angela, would you repeat that question?
Can a person suck on a damp towel if unable to swallow? No chance of choking on liquids. I'm not sure if this is in reference to VSED or maybe it was one of the earlier comments.
I'm not sure if they can't swallow, and that is actually going to be beneficial to helping them not drink any water. But yes, you can, you know, part of the care that's for the oral care is a misting the inside of the mouth, you know, with a light mist, you know, spitting anything out. A suck on a towel is fine as long as you're not able to squeeze, you know, big gulps of water out of the towel. But yeah, that's absolutely fine.
And then the next question is, would you give morphine to alleviate pain?
Yes, absolutely. With hospice involved, that is a primary importance that they're involved and would issue morphine and any other maybe medication that might help with, you know, anxiety, stress, you know, but morphine for pain, yes.
Okay. And then you went over this in your slide presentation. This was before you gave the timeline to VSED, but says can only survive 3 days without water, question mark. Also, no IV fluids given, question mark.
That's correct. You can only survive, you can survive longer than 3 days without water. Yeah, you can, like I said, yeah, and that was the timeline. So the timeline, I mean, it just varies. It's part of that, I think I said earlier, like it varies so much how long it takes, and fluid retention was one of those factors. Like people just retain fluid longer, and so they can last longer. And some people do die within 3 days. And so, you know, there's so many of those factors that determine how long someone can go without any water, but it can last. I mean, it can last a long time. It can last up to 28 days, which is pretty amazing. And maybe sometimes, you know, I don't have the specifics, like even sipping on a little ice chip, taking a tiny sip of water, those will lengthen the process. You know, it's not like you're taking a glass of water, but people, you know, yeah.
So the next question, we can kind of, what you just said goes along with that. Could the person undergoing VSED take anything at a legal prescribed dose to speed up the process, such as diuretics?
So can they take anything at a legal prescribed dose? Well, you want to stop all, it's talking about taking a medication?
Yeah, I think
Or
they're referring to diuretics, which would, you know, maybe quicken the water coming out of the body.
And so, so say it again. Would you repeat it again? Because then I lost. What was the question, Angela?
Could the person undergoing VSED take anything to speed up the process? An example like diuretics.
Yeah, I mean, yeah, a person. I don't know that it will speed up the process. That would be my only comment. It's funny, you know, with VSED, even though, you know, you are stopping eating and drinking, and it is dehydration that hastens your death. You could take a diuretic to speed up getting the fluids out, but sometimes that readiness to let go can also hang on. So it's real, you know, it's so hard to have a guarantee. Unlike medical aid in dying, you know, we know that when medical aid in dying, you know, a person is given you know, a combination of drugs that are guaranteed to end one's life within, you know, I mean, you know, 1 to 3 minutes, 5 minutes, you know, but with VSED, it just depends. There's a lot of factors, and one of those is willingness to let go, and your previous health history and your weight and your height. And so that's all I can say to that one.
So the next question, will you please speak to comparing, contrasting VSED to medically assisted death?
Right, so the medical aid in dying. So medical aid in dying in Oregon here. So it's a, you know, it's a cocktail of medications, 4 of them, and each one of them is a lethal dose. So you've got 4 times lethal. So it's extremely, you know, they've worked on the drug formularies, been tweaked over the years. We had it legal here in Oregon, and when somebody wants to use medical aid in dying, the first requirement though is that they have a 6-month end of life diagnosis. So with VSED, you don't need that. And with the medication, you know, it's just, you know, it's a planned death, and people get their affairs in order, and they choose the, you know, the day and the time that they would like to take the medication. And sometimes we're there with them if they want, sometimes not. And they drink the medication, and you know, and it's over really quickly. VSED, as you know, I discussed here, it really takes pretty amazing self-determination. It's not an easy option to carry out. And you know, like I said, it's, you know, anywhere from 1 to, you know, 14 days averaged time. I know some of that time during the end, you know, you are pretty much sleeping and then into a coma until you pass away, usually from heart arrest, you know, cardiac arrest. But VSED is much more challenging, and having good care support is really important.
Renee says, even states without MAID, medical aid in dying laws, such as Arizona, have end-of-life doula organizations. Some of those doulas might be receptive to support VSED. So what are your thoughts on the role of end-of-life doulas in that area?
Yeah, and I'm sure tomorrow, I mean, the next time they can really talk about that even in more detail. But my experience is that doulas, yeah, I know I would be supportive to the family and supportive to the client. But that would be as far as my support could go. I mean, I could definitely help them with resources in terms of, you know, finding, you know, how to find caregivers. I could also, you know, work with caregivers in terms of the interview process to make sure, kind of vet them to make sure that they are able to morally, consciously, and emphatically support this client and their wishes, and then, you know, help train them. So these are some of this would be the scope of my work in terms of working with them. I would, yeah, just make sure that they had 24-hour caregiving support, that there was no food being cooked in the house, that if the care, you know, whenever somebody wants to eat, they must go in a different room, you know, and so this kind of, you know, things like this to increase a good success and peaceful, you know, a peaceful process.
Okay.
Angela, this is Nirmala. I have to sign off, but I have a little early. I have a few questions. Could I just go ahead and verbally ask them?
Yeah.
Okay, thank you for a great presentation. And maybe I missed it in the first couple of your slides. Is this a VSED recognized, say, by the AMA and by kind of national palliative care associations? That's my first question. And my second question is, in my research, a lot of people at end of life are decisionally incapacitated due to either the disease process, medications, treatments, combination. How do you assess for decisional capacity before someone decides on this voluntary action? Thank you.
Right. Okay, thank you. So, and to respond to the last thing you said, the end of life incapacitated. So, they must have capacity when they begin the process. So they must have capacity.
Do you assess for capacity?
No, I don't assess for capacity. It's, you know, again, the VSED it's legal and it doesn't need an oversight by anybody. You know, I could choose today to do VSED. The capacity, the importance of capacity comes in when during the, during the process, if I decide to change my mind, but I forget, I'm like, why I'm doing this, and then the caregiver saying, well, you here's the video you made, do you still want to do it? And if I've really lost capacity, meaning that I have advanced dementia, I wouldn't be able to remember, and I would have to just stop. So the capacity starts from the beginning of your making that video and saying, I want to do this, and then when you go into a delirium state, you know, I think there's a difference in going into delirium and being, you know, not having capacity, where you just have, yeah. So does that answer that question for you?
Yeah, it does. Yeah.
Yeah, it's a little different than you know, having to have, you know, capacity in order to, you know, like they evaluate you if you want to change your trust. Yeah, okay. And then as far as the other was, is this embraced, did you say, by the palliative care association?
Is it recognized as a best practice by, say, American Medical Association, any of the national palliative and hospice care associations? I'm just curious.
Yes, so I think your question is it recognized as best practice with the American Medical Association and or the Palliative Care Association, right?
Yes.
Yeah. So because I am not a part of the association, I don't want to answer that question because I don't know what they define as best practice.
Okay. Well, that could be something Angela can research later. So
I do know that when it comes to hospice, that it is recognized by hospice associations. And maybe not all hospices will take part in it, but I know that a majority of the ones in our area do support
good to know.
VSED.
Yeah. Okay, thank you.
You're welcome. Yeah. It's you know, VSED is starting to gain popularity, and you know, I'm noticing more articles on it. I noticed you know, Compassion and Choices, which is the, you know, national organization, just did a presentation on it yesterday. So and like I said in my presentation, you know, each individual doctor and hospice chooses, you know, whether they want to support it or not. Yeah.
So we do have just 2 more questions. The first one is, are there any meds that act centrally to alleviate the feelings of thirst rather than just the mouth care?
No, it's really no, it's the mouth care though, you know, the biotin, you know, all the different mouth care, the biotin and the salves. But in terms of alleviating thirst, the thirst sensation, no.
Okay. And then Was there something more you're going to say?
No, just, sometimes, the spritzing of water, wiping the inside of the mouth, with, with the moisture thing, all those palliative care things. Those are the only things that happen, but not to alleviate the actual thirst. Go ahead, Ann.
And so the very last question is relating more to medical aid in dying law. And so when does the new Oregon medical aid in dying law negating the need for residency take effect?
Well, it's already in effect, and I believe that took effect. I don't have the exact date, but it took effect maybe a little bit more than a month ago, just very recent. So it took effect, and we are actually beginning to get quite a few inquiries from other states. When someone does use a medical aid in dying from out of state, there's, various, different requirements. They have to come here for the whole entire time. They can't just come here, get the medication and go back. They have to, they come here and they need to stay here for the, enroll in a local hospice, have local physicians, and, and stay here for the whole time.
Okay. Well, we have 1 more minute left, and I really want to thank Debra for presenting today and everyone for attending. We will be sending out the emails, so please keep a lookout for that. And yes, thanks everyone.
Well, thank you. Thank you so much, Angela. And I hope I was able to answer everyone's questions. Okay, bye.
Bye. Have a good week, everyone.